Welcome back to the How We Can Heal podcast. I'm happy to be back from parental leave to share some incredible guests and conversations with you this season. I created this podcast because I'm surrounded by people who have dedicated their lives to navigating healing. There is so much wisdom in each guest, and my hope is that this show makes their important ideas and experiences available to you in a way that uplifts and inspires you. These guests and I have committed our lives to fostering health and joy in the world, even as we work through the impacts of trauma and face deep challenges. Let's dive into season 4 and let's keep talking about how we can heal. Welcome back to the How We Can Heal podcast. Today, our guest is Dr. Ruth Lanius. Dr. Lanius is a professor of psychiatry and the director of the Post-Traumatic Stress Disorder Research Unit at the University of Western Ontario. Her research interests focus on studying the neurobiology of PTSD and treatment outcome research, examining both pharmacological and psychotherapeutic methods. She has authored more than 150 published papers and chapters in the field of traumatic stress and is currently funded by several federal funding agencies. She lectures internationally on the topic of PTSD and co-authored Healing the Traumatized Self, Consciousness, Neuroscience, Treatment with Paul Fruin. Today, she shares that she has another book in the works, and I look forward to reading it. Ruth and I connected initially through the International Society for the Study of Trauma and Dissociation, and I have a deep appreciation for all she's contributed to the research and practice of healing trauma. Let's welcome Ruth to the show. Ruth Lanius, welcome to the How We Can Heal podcast. I am so excited to have you here. You've done so much amazing work in the fields of trauma and dissociation, and I know you get recognition for that, but I feel like even recently I've heard all these things like groups you were a part of, I don't know, like guidelines or behind the scenes stuff. So I just feel like you've been doing this work for a very long time with a lot of heart and a lot of dedication. So I want to acknowledge that and I want to thank you for that. And I'm very excited for our listeners to hear from you today.
Well, thank you for having me, Lisa. I'm thrilled to be here.
Yes. So I was just letting you know before we started recording, I usually start with like, how did you get here? And, what's your path? And I want to hear that. I really want to hear that. But there's something I want to hear a little bit more, which is, again, you've been doing this work for decades. And, I've been in the work for 2 decades. You've been in for more. I know there's times where you start to feel like a plateau with information, like we're all circulating around these same ideas or studies need to repeat themselves. And then there are moments where, we get really curious about something new. So I'm wondering where you are and what, if anything, is lighting you up right now in the work. What questions are you feeling drawn to? What do you hope we find out in the coming days and years?
Yeah, that's a great question. And a lot of things are lighting me and my group up. So I should say up front that I work within a group of wonderful clinicians and researchers, and we sort of explore trauma and the brain and novel treatments together. So it's really a lot of fun. And I really feel I'm a student of psychotraumatology. I learn every day from my patients, from the brain scans that we see, and from some of the new treatments that we're doing. And so what excites me the most right now, and I think it's a couple of related things. One is how the subconscious brain can hijack the conscious brain. And let me be a little bit more specific, and please ask me if it doesn't make sense, Lisa. And so the subconscious brain, I think, is very deep within the survival brain or the reptilian brain. And it's in our brain stem, and it's really crucial for some of our basic functions. So breathing, digestion, the mind-body connection, and of course also really reflexive trauma responses where we react without thinking. So defensive responses, whether we fight or flight or flee, or whether we shut down or whether we freeze.
Yeah.
That's all subconscious brain, and these processes occur automatically, right? We have no conscious control over them.
Yeah.
And deep within that brain, we also experience raw emotion, right? which we have in common with animals. So raw terror, raw fear, raw anger, the visceral feelings of shame and guilt. And what we're learning is that these deep brain structures, especially, trauma-related raw emotion and arousal, can hijack our conscious brain. And by our conscious brain, I mean, the brain processes that we're aware of. For example, when we think about ourselves, or when we think about others, or when we actively engage in a task. And I'm thinking specifically about a brain network that I think really represents who we are in the world, or our sense of self. And that's called the default mode network.
Yes.
And this network seems to become hijacked or driven by this subconscious brain, specifically the region that's really involved in trauma-related arousal and raw emotion. And I think what happens with that is that we then, when our conscious brain becomes hijacked by our subconscious brain, we start to see ourselves and the world through a trauma lens.
Yes.
For example, I am bad. I'm a horrible person. I don't deserve anything good. I don't feel safe. I can't trust anyone. If I see myself this way, then that also really affects how I see the world. Right?
Yes.
I start to see the world as an unsafe place. I don't belong. Right? Which really, I think, is at the core of trauma.
Yeah.
And so, of course, thinking about this really points us into the direction, well, if this is what's occurring, then how do we treat it? How can we intervene at such a deep level to calm that subconscious brain, right? That is full of hyper and or hypoarousal, full of, raw emotion and affects the rest of the brain. So how can we calm that and really uncouple that from who we are? Really excited recently, we've been doing a big randomized controlled trial on a psychotherapeutic modality called Deep Brain Reorienting.
Ooh.
And developed by Frank Corrigan in Scotland.
Yes.
He's really a brilliant psychiatrist. I don't know if you've heard about deep brain reorienting.
Oh, yeah. I feel like it's getting increasingly popular. So I'm really glad you're studying it.
Yeah. And so the way Frank developed deep brain reorienting is really to target these deep brain levels, right? That are so critical in trauma and that I think we haven't thought enough about.
Yeah.
And I think by really targeting these deep brain levels that are, the foundation of trauma, we're getting at the root of trauma. And it's like getting at the foundation of the house. We're stabilizing the foundation. And by stabilizing the foundation, the whole house and the whole person will stabilize.
It reorganizes, right?
Exactly. And it reorganizes first from a bottom up kind of way, but then, of course, also top down, right? So I think it's a really beautiful way of, starting from bottom up. And then also, once we've organized from bottom up, then we also begin reorganizing from top down.
I love that. It's so powerful. And I love using, because so much of what we do in psychotherapy doesn't feel tangible, right? It's relational, or it's internal, or if we don't have a physical brain scan, fMRI to look at, how do we touch it? So a house, you can easily think if there's something off in the foundation, it's just a little to the left. It just got pushed that way a long time ago. And we reorganize it. We just push it back to the right. Then everything above is more steady, and there might be some readjusting with things above. And that might mean you need to go back to the roof and make sure the roof's okay, and then go back down.
Right. And so I think this deep brain reorienting, it gets at the subconscious brain. They get triggered over and over again, and they feel this loss of control. And, many times they don't even know what's triggered them, right? It's that deep part of the brain driving the distress.
Yeah.
And so, I think it's a critical part of the brain that we need to get to.
Yes. I want to ask more about the studies you're doing on deep brain reorienting, but I also want to say that what you're sharing, I think, is so relatable. We have a lot of therapists and mental health professionals listening to this podcast. They're familiar with trauma and dissociation. We also have a lot of folks who are just like, hey, I'm dealing with this, or my neighbor, or my roommate, my friend. And I think the subconscious versus conscious, like that's enough in popular lexicon. People understand and most of us have a felt experience of, I want to go this way. And then something within us stopping us,
That's right.
right? Like it's not safe to go that way, or in a deep way, our body or our entire brain isn't on board. And then there's conflict, and then there's struggle or strife. But we often set intentions or resolutions and then find ourselves back at square one. And I think this internal conflict or struggle is just a really common theme across counseling and psychotherapy. And you mentioned a few really powerful, easily said, not easily done things, which is uncoupling trauma triggers from identity, from self, from worldview. And that, I think of some of the moments of transformation that I've been a part of. To change your worldview in a significant way, I think, there's interventions that you're studying that can help. But it also, I think, requires a lot of trust of someone else's perspective at times, right? Like I think in a therapeutic relationship, someone challenging, maybe that isn't the ultimate truth. I just want to echo that there's a lot of obviously application and power in shifting that foundation, in reorganizing so that we can be open to truly growing and maybe integrating our brains, our minds, our senses of self in a way that helps us move in the direction we're wanting to go.
Absolutely. And I think it all starts from within the body and within the viscera, right? Those visceral sensations that are tearing us apart in the aftermath of trauma, I think are often driving how we view ourselves and the world, right? And if I'm engulfed by visceral sensations of terror or shame, I mean, the way I view myself and the world is going to be profoundly different as compared to after treatment, when I can actually drop it into my body and feel those visceral terrors have soothed themselves and have really subsided, right? Then that opens a whole new possibility of how I view myself in the world. Right? Does that make sense to you?
Yes. And it's a whole new possibility of connection. Like what I was just saying in terms of, my role as a therapist, thinking about having these conversations with folks. And if you shift something internally, I do a lot of work with, somatic work and yoga. And if there's a physiological shift, and this is what I love about this type of work, is if you sort of target that physiological shift and then come back to the thing, the problem or the belief or whatever, it shifts on its own. And then that connection or that trust feels possible. Whereas in what we might call a triggered state or a dysregulated state, we could use all kinds of different language, it doesn't feel possible from there, right? So I think these interventions help make that healing experience, like they build, right? And then another healing experience is possible.
And then we make new meaning, right?
Yes.
Yeah.
Yeah. So let's talk about the deep brain reorienting studies. What are the questions you're asking? Do you have any findings yet to report? Even, soft findings that you're working on publishing?
Yeah. So we're doing a randomized controlled trial of individuals who have a diagnosis of post-traumatic stress disorder. And we have a range of individuals in this study, from moderate post-traumatic stress to, really severe post-traumatic stress. And we have a number of individuals also with concurrent dissociative disorders.
Okay.
So it's really, a good range of individuals. What I'm actually most excited about is that I've been doing a lot of deep brain reorienting with some of my clients, and some of them I've seen for many years. And of course, when you're in that situation, some of your clients have plateaued, right?
Yeah.
And for most of them, introducing deep brain reorienting has actually gotten them out of that plateau. Wow. So that really excited me, and I think that's why our group actually then embarked on an official randomized controlled trial of DBR. And we have some interim findings published where we show a strong effect size. And, people, really reduce their post-traumatic stress disorder symptoms. What we're also finding is that their physical symptoms are decreasing and that the symptoms of depression are decreasing.
Nice.
And really what patients are reporting, and of course, that's often the most exciting part of the study, is to really get the first person perspective, right, of individuals going through this. And what they're really reporting is that they're able to drop into their body, right? Their body is their home now. And, many of them are very, very disconnected from their body. And so it's really been a remarkable journey to really learn and understand from each individual what changes they've experienced.
Yeah.
And for most people, a treatment never works for all.
Yeah.
But for, many, many people, this has been a really life-altering experience, I think. What I should also point out is that this is only 8 sessions.
Okay.
And we started the study during the COVID-19 pandemic. So actually the treatment is online.
Wow.
And that's also been very interesting, especially for some of our severely traumatized clients. I think sometimes online decreases the hypervigilance, right?
Yeah.
And they can be within the safety of their own home. If they have an animal, it can be with them. And so, they've done very well. And, when we first designed the study, we knew from some pilot findings that, 8 sessions would probably be a good number of sessions. And it's really worked out that way. And, I want to stress that, of course, we don't cure everybody, right? And I never want to say that, this cures everybody, 8 sessions. But I think there's something to the 8 sessions. I mean, you're processing difficult material. And so knowing that there is only 8 sessions, I think can be helpful for people because, it's easier to push yourself through 8 sessions.
Right.
Right. And then know you're done. And so I think the 8 sessions has really worked out very well. And we have very minimal dropouts. And people have really feel that this has changed their life in many, many cases. For example, we had a man with a dissociative disorder and complex dissociative disorder. He'd been, I think, in 20 treatments to date. And, he was barely functioning. And, he'd been told basically that he's a hopeless case. And he did remarkably well with the DBR to the point where he lost his PTSD diagnosis after.
Wow.
He wasn't cured, but I mean, remarkably better. Yeah. And what was really exciting was that his psychiatrist actually did the DBR training because she saw that this was the only thing that had helped them so far.
That's amazing.
And, it's designed to get at that foundation, to get at the root, right? To get at that subconscious brain, that survival brain, that reptilian brain, to calm that. And by that, change all the connections to the higher parts of the brain. And then new meaning, new ways of seeing ourselves and the world emerges. And it's been incredibly rewarding and amazing to watch some of the individuals really recover.
And I can just see your face light up at that, right? And I know from working with people for at least a decade that those plateaus are hard for everyone, right?
Absolutely.
And when we find something that works, it's really exciting. And I have 2 big questions that I'm wondering about this study and about the work in general that you're doing with DBR. The first one is because you said that you include people with PTSD and dissociative symptoms as well. From my understanding, and we've invited Lauren LeBlanc on the podcast who has presented on this, as well as Simone Reinders talked a little bit about it. But from my understanding, we see different patterns in the brain with like hyperarousal PTSD and dissociation. And like you said earlier, it's coming from this deep part of the brain, from the brainstem, and there's a lot of directions that can go, right? It can go into fight, it can go into flight, it can go into freeze, it can go, we talk about like social adaptation and appeasing and things like that. What I'm wondering is, do you see a difference in folks who have classic sort of hyperarousal PTSD versus a dissociative subtype or a dissociative diagnosis in how they're interacting with DBR, or in how they're showing up in the data and the studies? Has anything come up so far to kind of differentiate that?
We will be able to look at that. We don't have the data yet, so we'll be able to have clinical data, and we will have brain imaging data. And I'm very excited because we're using a very special scanner at a very high magnet strength, 7 Tesla. And so that allows us really to look at the deep part of the brain as well. So we will have those data, but I can speak clinically about what we've learned about doing DBR with, the classic PTSD versus PTSD with high dissociative symptoms and PTSD with comorbid dissociative disorder. And I think what we're learning, and I think we're seeing this with other treatments as well, so this is not unique to DBR, when somebody is highly dissociative, we go slower.
Yes.
Right? We check in with the client more.
Yes.
Right? Whereas somebody, with more classic PTSD, the session may be mostly silent. If we have somebody with complex dissociative symptoms, we would check in more. And of course, they're also more prone to emotional overwhelm or emotional shutdown.
Yes.
And what's really good about DBR is it's a very sequenced approach. So where we orient the person to the present self, where they are on a chair, and what's immediately around them. We get them to relax the muscles in their face and in their shoulders. And then we ask them to bring up a trigger. So that, this can be a memory, or this can be a trigger, what we would call in the field a more minor trigger. For example, they made dinner and their partner criticized them. Right? And of course, the criticism then usually goes deep, right, from an early attachment figure. And we then ask them to bring up that image, and as they bring up the image, we ask them to identify the orienting tension, because the first response we have whenever we're faced with a stressor is that we orient to it or away from it, right? And that occurs deep within the brainstem at the level of the superior colliculus, which connects to the muscles in the neck. And so we're trying to really get the tension associated with orienting to that stressor first. And then the individual can let go of that image, and we just get them to notice that tension in their head and neck. And that's the anchor that we use throughout the treatment for them to stay within their body.
Yeah.
And if they get overwhelmed during the session, we actually say, okay, we're going to back up to the head and neck tension. So they remain embodied, so they don't lose that connection with their body. And so if we have a highly dissociative client, this is something we would do more, right? We really watch, are they numbing out? Are they getting too hyperaroused? Yeah. And then we back up into the head and neck tension before we process more shock or more visceral emotion. And so, I think in these highly dissociative clients, go slower. We always start with milder triggers.
Yes.
Right? So they can stay within that window of tolerance. And we're obviously attuned to all clients, but we're especially attuned to any emotional overwhelm. And then if the client feels it would be beneficial, then we back up into this head and neck tension so they stay embodied. Does that make sense?
It makes total sense. And I think the skillfulness you're describing is what I often see missing in overly eager trauma therapy approaches, right? Where it's like, let's just get in there. Let's just reorganize the foundation, because there can be a lot of urgency around healing trauma. I want to get it done. You want to, like, the therapist wants healing. The client wants healing. And I think it can be still for some, and I think especially in sort of mainstream psychotherapy or counseling, like if people aren't aware of dissociation, you can plow right through it because someone shut down and then they look okay.
Yeah.
Or they get flooded and they're one person out of 10 on the caseload, and the person just goes, I don't know what happened there. So that skillfulness that you're describing in attuning to and meeting the needs of dissociation, of pacing much more slowly and being aware of those places it can go really quickly, right? It can go really quickly to flood it or hyper arouse. It can go really quickly to shut down or numbness or anything like that. So I just really appreciate that skill, and it makes so much sense. Like once you hear it, I think it's hard to unhear. Like it just makes so much logical sense that we would do that. So, and you answered my other question, which was, do you find you need to pace differently with folks with dissociation? And so the answer is yes, with deep brain reorienting.
Absolutely. And I think you also do it through the triggers that you use. So if you're using, a daily trigger, you still go deep, but you go deep slower. And I think it's more controlled rather than going right to the hot spot of the memory, right? So I think that really helps to control as well. And the other thing that I think is very exciting about DBR is how freezing responses are processed by clients. And so I'm used to, if my clients go into a freezing response during trauma processing, it stops, right? You hit a wall. And I think with deep brain reorienting, what I've seen over and over and over again, the trauma processing doesn't stop. It continues. So the client is partly frozen, but they can continue to process the freezing and overcome it. I think that's a very important part of DBR. And I recently did it with one of my severely traumatized clients who has a lot of freezing. And, her entire childhood, she was afraid to move. And we did DBR, and she had a freezing response that during the DBR session that she was able to process through. And the way she put it was, this is the first time I didn't disappear while I froze.
Wow.
And so I think that's very important as well, because these freezing responses are very difficult, right, to process.
Yeah, they're strong. They're strong, and they can be really difficult to process. And I think as a clinician, we can feel like, what do I do now? Right?
Yeah,
like,
we feel stuck, right?
We feel stuck right alongside. Yeah.
Yeah, we feel frozen.
Yeah. Yeah.
Right?
I love it.
Yeah.
And I just love listening to you describe it too, because I come from the land of yoga, and I think of things in terms of yoga. And every time I do a training, I'm not trained in DBR yet, maybe I will be, but I always, that sounds like yoga. We get really present, we orient to the room, we go in, we soften the muscles in the face, we go into the tension, we come back out of it. Like all of that is so similar. So it makes me think of some of the yoga work I've done that's not this method, but shares some
of course.
approach. Yeah,
absolutely. And many methods share things with deep brain reorienting. I just think there's some unique aspects of it.
If you're listening to this podcast thinking, I want to learn more body-based tools to help support trauma recovery, then you might be the perfect candidate for the Yoga for Trauma online training program. This 8-week certification is for wellness providers and enthusiasts who want to learn the theory and best practices for providing yoga and somatic tools to those navigating the impacts of trauma. Students often come into the Yoga for Trauma online training program, or Y4T as it's come to be known, knowing at a deep level that mindful movement can help with trauma recovery, but not knowing precisely how to articulate it or share these tools with others. Y4T breaks it all down and leaves you feeling clear about your choices as you support folks navigating post-traumatic stress. Of course, the experience is good for you too. With 8 modules and 8 yoga classes, you'll get a taste of how it feels to practice yoga in a trauma-responsive manner. Head on over to howwecanheal.com/Y4T to apply and join the program today. Mention the podcast in your application for a special bonus. One more time, nice and slow. The website is howwecanheal.com/the letter Y, the number 4, and the letter T. Looking forward to seeing you there. So I want to shift gears and ask a little bit about neurofeedback, because that's another intervention that you've studied and that still, I mean, I think I did the training in, I don't remember now, 2013 or something. But I still feel like it was coming a little more mainstream from my view. And then I don't know that it fully landed there, but I think it can be a really powerful treatment. So I'm curious about what you found, and I have, kind of my own question that I want to ask, and we don't have to go straight to it, but what have you found in general in terms of neurofeedback with folks with PTSD versus more of a dissociative presentation?
Yeah, and so neurofeedback, I think, is also very important adjunct treatment for people with complex trauma because, again, we're targeting the brain directly. And with neurofeedback, our group has actually shown that we can also target these very deep brain areas that are very difficult to access with many other types of therapy.
Yeah.
And, when we first see patients, often, there's no words, they don't want to talk, right? And so neurofeedback is a way, I think, of just kind of getting or widening that optimum window of tolerance, right? And really regulating that arousal so people can start to be a little bit present. And of course, to be present in order to get through therapy.
Yes.
And the more present you are, the more emotional learning can take place and the more you can take in. So I think it's a beautiful approach to actually combine with therapy. And that's how I've learned about neurofeedback after Stephen Fisher and Bessel van der Kolk first introduced me to it years ago.
Yes.
We've also seen some astounding results with neurofeedback, especially in the highly dissociative clients. And again, you have to titrate, you have to dose, right? Because increasing awareness needs to be done at a pace that feels safe to the person, right?
Yes.
You can't just, pull them from being completely dissociated because, that's an escape when no physical escape is possible, right?
Right.
The client slowly needs to adjust to, being in the present. And so, again, you have to work, I think, with each individual person to dose that in a way that feels safe for them.
Yeah.
We've seen some amazing results with, neurofeedback to really decrease some of the dissociative symptoms.
Yeah.
I remember as I was working with a man, he was so dissociated, he could only, I think, get about 15 to 20% of conversations he was engaged in. And this was one method of really helping him, come into the present and actually be able to follow a conversation.
Yeah.
Or I had a woman who had really helped with, becoming aware of what was happening inside and really, just getting a much clearer picture of her internal landscape. And we see that very often.
Nice.
One last thing, and now what I find very interesting, people who are doing DBR, they're demanding neurofeedback.
Oh, really?
Usually it's part of our session, but I haven't seen people, demand it, but I've seen that more. So it's going to be very interesting to study that combination.
Yeah. Is there a particular type of training that you're studying with neurofeedback? Because I know once you get into the world of neurofeedback, there's different schools, there's different approaches. There's this like SMR and infralow and alpha theta. Is there a particular protocol or approach that you're studying?
Yeah, so we study the alpha neurofeedback, so decreasing alpha.
Yeah.
And alpha is the main rhythm of the brain. And what was beautiful about this approach is that the brain actually shifts in the way it needs to shift. So
Mm.
some people with PTSD have too much alpha,
Yeah.
and some have too little alpha.
Interesting.
And so when you're training the alpha in people who have too little alpha, they actually get a rebound. And over time, their alpha increases. Whereas people who have too much alpha, we see this brain rhythm decrease over time.
And that was exactly my question, was around the role of alpha in what you're seeing with the different sort of presentations of PTSD. Do you find, is there any correlation you found between hyperarousal PTSD, less alpha? And I should back up because, some folks listening might not even know like what is an alpha wave and what does that mean if someone's in an alpha state. So we can circle back to that. But in general, it's like that relaxed awareness wave, like a little bit below fully engaged with the present moment. Maybe it might be meditative, it might be hypnotic, right? So I would guess that people with more hyperarousal symptoms would have not a lot of alpha, and people with dissociative symptoms would have too much or a lot. Is that what you're seeing?
We've seen that in case studies, and we want to look at that in larger samples now. Yes.
Okay.
And I think this is one area of the field where we really need to look at the effects of dissociation.
Yes.
Because again, we know that a lot of PTSD patients have decreased alpha, but we don't know enough about the specific effects of dissociation.
Yes.
Yeah.
It's so interesting.
Yeah.
I did neurofeedback training years ago, and then I just did a ton of sessions on myself, right? I did them as part of training, and then I did them once I got the apparatus to use in my practice. And it was so interesting because I had these little changes, like my reaction time on the brake pedal when I was driving got a lot faster. So I had to adjust to that. And I also felt like, I think I'm someone, I always look at my EEG after. I'm like, I want to, it's like tarot cards. I want to be like, what does this mean? And I don't have a ton of training in that like some people do, but I always look at it and I'm like, oh, my alpha does look, I think I'm a higher alpha person, right? I do a lot of yoga. I feel pretty present, in most conversations and places. But after I did a ridiculous, I did like 80 sessions on myself or something.
Yeah.
I noticed that I did have a little less of this like dreamy effect of life. Like it didn't feel quite so, there was like a softness that went away, and it wasn't bad, but I kind of missed it, and it was subtle. It wasn't this drastic change, but there was like a fuzziness around the edges that just sharpened or got a little clearer. And it was so interesting for me to go through that process and go, oh, but that was cozy. I liked it. And I wasn't, dissociating big parts of myself or memories. There wasn't like a big integration process happening through my neurofeedback. But that gave me a little taste of what it might feel like to kind of take off the security blanket, if that's what it's doing. And I know we're so different. We could never step into someone else's nervous system or body and fully know what the other person's experiencing. But it was a nice little taste for me just to go, oh, like this is great. And there's a little compromise in it.
Yeah. And that's something you have to process then with your therapist, right?
Yeah, exactly. Exactly.
Yeah, I remember doing it with one of my patients who, had spent about 8 years in hospital before I started seeing her. And I had done years of psychotherapy with her. And, she, got back to getting a full-time job, a social life. She's really, a tremendous improvement. But then she was re-exposed to her perpetrator. And that triggered her back into severely dissociative states.
Yeah.
And this was just at the time we started doing the alpha neurofeedback. And so I said to her, is this something that you'd like to try? And she said, yes. And so I think because she had so much preparatory work and she was ready, within 4 sessions, she described, actually, as she said it, ramming back into my body.
Wow.
And feeling all the emotions. Now, she had years of therapy and she had all these skills, But it was an identity crisis, and we had to work through that.
Yeah.
And after she said, I'm so glad because now it's the first time I can experience real happiness.
Wow.
Because, she needed to be back. She needed to be fully in her body to experience those emotions. So, but again, she had that preparatory work, and that wasn't easy for a few weeks, right? We had to really process those changes she experienced.
Yeah. And I love that you're also describing there can be these intense periods of therapy, whatever intervention or approach you're using. And it is a little bit easier when they're concentrated, if you're doing 8 sessions or you've been in therapy for a decade or so, and then that these next 4 weeks might be really hard, or this next little chunk might be really challenging, but you have the skills to move through it. Kathy Steele and I talked about this, how it can be so challenging to find that edge of what's the right amount of pushing forward here, right?
Yeah.
Because we don't want to just hang out. We don't
No.
want to just hang out and circle back to the same thing. There's a little push forward, that's enough. And then there's progress. And we don't want to go too far, just like you described earlier. But there can be moments where this is hard work. This is really deep, the hard work of a lifetime, and it's valuable. And on the other side of that, if you're pacing well and you have the support, is I can feel happiness. I can feel the sensations in my body. I feel like myself. And other statements like that people come with.
Yeah. And yeah, I think that's the art of trauma therapy, right?
Yeah,
the
absolutely.
Pace, right?
Yeah.
And the pace varies over time.
It does.
Yeah.
And it varies from client to client.
Yeah. And it's a very collaborative process.
Absolutely. Yeah.
Yeah.
So we have just a few more minutes. I have 2 questions that I want to ask. One, I'm just curious, how'd you get here? How'd you get to be in this seat of studying trauma and dissociation? And how'd you get to become, a therapist doing this work, a researcher? What's the path that led you to where you sit now?
Well, it's an interesting path, Lisa, and an unusual path. So I think what led me to the brain was when I was in grade 12 biology, I won an award, and the award was a book about the brain.
Nice.
And it totally fascinated me, and it got me hooked on the brain.
Yes.
And then I studied medicine and neuroscience, and I didn't have a lot of clinical experience in those days. It was mainly book work. And so without that experience, I sort of thought about, what would be a good kind of specialty to go into where I can still do brain research. So I picked neuropathology. So basically working with dead brains.
Wow.
And then I finished my training and I started my residency in neuropathology. And when you start a residency, the first year is always an internship where you do, a lot of clinical work in different areas. And my first rotation was in psychiatry in London, Ontario, here in a small inpatient unit, 16 patients. And I had a great supervisor who really allowed me to listen to the patients and learn from the patients without interfering too much. And I found that most of these patients were trauma patients, even though they weren't labeled as such. And so I spent a wonderful month just listening and learning from my patients. And I thought, oh my God, I've made a big mistake. I can't go on in neuropathology. This is so fascinating. I could really see how the brain, mind, and body adapted to trauma, and how, working with these individuals, even though it's tough work, they can improve. Yeah. And so I became very passionate about trauma in that rotation. And then I approached my mentor, Peter Williamson, to help me switch out of neuropathology, which wasn't easy at the time, but he made it possible. And then I continued in psychiatry. And really started studying trauma very early on. And this mentor, Peter Williamson, allowed me to do neuroimaging studies, design my own neuroimaging studies because I had a neuroscience background. And so it just became, a learning experience, learning how the brain adapts to trauma, and individuals found that incredibly validating. And later on, I studied with Lisa Danylchuk as well in Boston for a few months. And yeah, it was just a wonderful learning experience, and it's continued throughout my whole career. I still try to learn something every day and learn from my patients, learn from our research, and then, discuss the findings with trauma survivors and make sense of them.
Yes. Oh, I love that. Do you have any studies going on now on intergenerational trauma or intergenerational resilience or anything along those lines?
No, but it's something we're planning, and also to look at how therapy not just affects the individual, but also the other generations. But actually, yes, we do sort of have a study going on. We're working with Patricia Vickers, who's an Indigenous researcher in British Columbia, and she's actually brought the alpha neurofeedback to several Indigenous communities in British Columbia.
Amazing.
And there we're looking at, of course, the intergenerational effects of trauma.
Awesome. Can't wait to read that.
Yeah, that's been an incredibly rewarding project, and I've learned so much. Our whole group has learned so much from Patricia.
Yeah. I ask this question to most folks as we wrap up, but I already feel like I'm getting a sense of it from you. But trauma work can be heavy, and there's a lot of burnout in the field. I think especially now in the last handful of years, global events and challenges and stressors collectively have weighed on mental health professionals, on health professionals, on folks in general. So what gives you hope and what keeps you going when things get hard?
My patients.
Yeah.
I mean, I think they really embody resilience, right? And even though they struggle, I mean, it's unbelievable, the creativity, the strength they bring to this work. So I think that really gets me going, and my group, right? Yeah. So the work I do is within a group, and we support each other. We debrief. I also have some really good colleagues. I can call up and say, oh my God, I have this case. I feel so stuck. I feel so incompetent. Can we walk through this case? So yeah, you need a community, right?
Yes. Yeah. 100%. And just having those folks you can call, and in those moments, I feel totally incompetent right now, right? Because that's going to happen.
Yeah, right. Totally helpless, right? And incompetent.
Right? Yeah. I was talking to someone recently about like trauma experts, and I was like, it's kind of hard to ever really feel like an expert because you're just humbled all the time. Like, here's a new person, here's a new scenario. Okay, right.
That's why I always say I see myself as a student of psychotraumatology.
Yes, 100%. Right there with you. Well, thank you, Ruth, so much for coming on the show. How can folks get in touch with you, read your work? What's the best place to send them?
The best place to send them, we have a LinkedIn page. We have a Facebook page under Ruth Lanius. We also have a few books. We have a new book coming out probably within the next year, where we have translated all we have done into lay language, and also into what this means for therapy. So look at the books. There's some YouTube videos as well, and we're going to have a website soon as well.
Oh, wonderful. Do you have a working title for the book that you can share?
Not yet.
Not yet. Okay. Keep us posted. We'll update it in the website and share that when it becomes available. Thank you again, Ruth, for all your work, for everything you do, for being here today. Just thank you so much from the bottom of my heart. I really appreciate everything you've done for our listeners today, and just for all of us in the field of psychotherapy and trauma and dissociation work. So thank you.
Well, thank you what you do, Lisa, and thanks to what the audience does every day. It's been a real pleasure being with you today.
Thanks so much for listening. My hope is that you walk away from these episodes feeling supported and like you have a place to come to find the hope and inspiration you need to take your next small step forward. For more information and resources, please visit howwecanheal.com. There, you'll find tons of helpful resources and the show notes for each show. Thanks for your messages, feedback, and ideas about the podcast. I love hearing from you, and I so appreciate your support. There are lots of ways you can support the show, and I'm grateful for every little bit of love you share. If you love the show, please leave us a review on Apple, Spotify, Audible, or wherever you get your podcasts. You can always visit howwecanheal.com/podcast to share your thoughts and ideas as well. Before we wrap, I want to be clear that this podcast isn't offering any prescriptions. It's not advice or any kind of diagnosis. Your decisions are in your hands, and we encourage you to consult with any healthcare professionals you may need to support you through your unique path of healing. In addition, everyone's opinion on this show is their own, and opinions can change, right? Guests share their thoughts, not that of the host or sponsors. I'd also like to send just huge thanks to our guest today, to Kyle Arizbal of Prolific Sound Solutions, and to everyone who helps support this podcast directly and indirectly. Alex, thanks for taking care of the babe and the fur babies while I record. Lastly, I'd like to give a shout out to my big brother, Matt, who passed away in 2002. He wrote this music, and it makes my heart so happy to share it with you here.